Welcome back, students, to part 88 of our Masterclass Explainer. I'm absolutely thrilled to be your lead instructor today as we tackle some truly fascinating material. Let's do a quick recap. So, in part 87, we explored the Advanced Medical DRG deep dive for MDC 06, which is the digestive system. Today, we're crossing the partition into the complex, high-stakes world of surgical coding for that exact same system. Now, before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Herschel. Here is our roadmap for today's deep dive. We'll cover MDC 06 surgical logic, high-volume digestive surgeries, ICD-10 PCS precision in CDI, audit defense, and, finally, our summary and teaser. All right, Section 1, MDC 06 surgical logic. Let's explore the highest level of MSDRG classification. The crucial point here is understanding the great divide within the MSDRG architecture. Basically, cases are partitioned into two distinct groups based entirely on interventions, medical versus surgical. And the golden rule you absolutely need to remember is that the presence of an ICD-10 PCS major operating room procedure completely overrides the medical diagnoses. It literally grabs the entire case and pulls it straight into a surgical DRG. The logic engine of the MSDRG grouper is actually a beautiful step-by-step progression when you break it down. Think of it like this. Step 1, your principal diagnosis, let's say acute appendicitis, establishes the MDC, which is 06. Then step 2, the surgeon performs an appendectomy. That's a major OR procedure, which immediately shifts us over to the surgical partition. And finally, step 3, your secondary diagnoses, like a comorbidity or a complication, jump in to determine your CC or MCC severity level. And that is what establishes the final payment tier. Moving right along to Section 2, high-volume digestive surgeries. Let's zoom in on the procedural complexity of these gastrointestinal operations. Surgical hierarchy rules dictate exactly how we handle highly complex anatomic cases across multiple DRG families. For instance, with major bowel procedures, we're looking at total, subtotal, and partial colectomies, as well as colostomy creations and reversals. Then you have stomach and esophageal procedures, which include gastrectomies and bariatric surgeries, where the digestive tract is entirely reconstructed with the remaining organs. For appendectomies, it's absolutely vital to distinguish between uncomplicated cases versus those with a complicated principal diagnosis, like peritonitis or a rupture, because those fall into much higher-weighted DRGs. And don't forget hernia repairs. Your coding there is heavily influenced by whether the hernia is strangled, incarcerated, or uncomplicated, plus the specific surgical approach used. Now, this brings us to a classic coding dilemma that frequently triggers audits. So imagine a surgeon starts a laparoscopic cholecystectomy, right? But due to severe inflammation or unexpected adhesions, they have to abandon the laparoscope and make a major open abdominal incision. How do we accurately code this conversion without triggering a massive compliance issue? Well, the specific mandate from ICD-10 PCS Root Operation Guideline B3.3.D leaves zero room for error here. You cannot just code the open surgery and call it a day. This strict rule dictates that you must capture the endoscopic inspection, the open resection, and a diagnosis code noting the conversion. Missing any single part of this sequence is pretty much a surefire way to fail an audit. Let's move into Section 3, ICD-10 PCS precision and CDI. We really need to dive into the absolute accuracy required when navigating the gastrointestinal system. Table 0DB dictates exactly how coders must meticulously build a 7-character code. It's almost like a puzzle. You match the section, the body system, and the specific root operation with the precise anatomical region, like using character 6 for the stomach or N for the sigmoid colon. Then you lock in the exact surgical approach qualifier. Was it an open approach with a 0 or a percutaneous endoscopic approach with a 4? Precision here is completely non-negotiable. In speaking of precision, differentiating your root operations is huge. Take excision, for example. That means cutting out just a portion of a body part, like a wedge resection of the bowel. That is fundamentally different from a resection, which means cutting out all of a body part, such as a total colectomy. Confusing excision and resection will completely derail your DRG assignment, so you've got to nail this down. As we know, surgery doesn't always go according to plan, and when clinical documentation reveals unexpected twists, these specific root operation rules are your guiding light. For example, under Guideline B 3.3.c, if a surgeon destroys the sigmoid lesion and then bypasses the sigmoid colon, those are distinct objectives on the exact same body part, meaning they must be coded separately. Or look at Guideline B 3.4. If a procedure is discontinued early before the main event even happens, you must code it to the root operation actually performed, which very often defaults to a simple inspection. So why does clinical documentation improvement, or CDI, matter so much for these surgical cases? Well, capturing high-yield secondary diagnoses, things like a prolonged post-op paralytic ileus, an anastomotic leak, or septic shock, can trigger a major complication or comorbidity, known as an MCC. Moving from a base relative weight to a high relative weight because of a captured MCC can literally more than double a hospital's reimbursement for the exact same surgery. It's a massive deal. Which perfectly transitions us into Section 4, Audit Defense. Because these surgical DRGs carry such high financial impact, they are huge targets for payer denials. To defend the clinical validity of postoperative complications versus expected surgical sequelae, experienced coders have to back up their CDI teams. We do this by rigorously verifying the core documentation pillars. You have to ask yourself, is every diagnosis clinically supported by lab or imaging evidence? Are the present on admission flags accurately distinguishing a pre-existing comorbidity from a true hospital-acquired complication? If the record is ambiguous, we absolutely cannot just guess. Sometimes you just have to ask. When documentation is vague, which leads directly to revenue loss and compliance risk, using a targeted CDI query template is absolutely essential. Asking the physician to clarify the exact acuity or underlying cause of a condition establishes the specific, bulletproof documentation you need to secure and defend the correct DRG. All right, let's bring it all home with Section 5, Summary and Teaser. Let's wrap up today's comprehensive explainer. To summarize what we've covered today, from navigating the MS-DRG triplet structure, to understanding that major OR procedures shift our entire coding pathway, to defending your root operation choices between excision and resection, precision really is your greatest asset in abdominal surgical coding. Never underestimate the power of exact anatomical knowledge and a well-placed, thoughtful clinical query to safeguard your case. Next time, get ready to shift gears because in Part 89, we are exploring the hepatobiliary system and pancreas. As we close out today's lesson, I want to leave you with this question. Are you merely assigning codes, or are you truly translating the complex clinical story of a surgical patient? Think on that. And if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal.